Ladies and gentlemen, thank you for standing by and welcome to the COVID-19 Media Briefing Conference Call. At this time, all participants are in a listen-only mode. After the speaker's presentation, there will be a question-and-answer session. To ask a question during this session, you will need to press star one on your telephone. Please be advised that today's conference is being recorded. If you require any further assistance, please press star then zero. I would now like to hand the conference over to one of your speakers today, Mr. Mike Schomer. Sir, please go ahead.
Thank you, and thank you for joining us on the COVID-19 media call for July 20th. We'll start today's call with a situation report from Health Commissioner Jan Malcolm. We'll also hear some opening comments from Infectious Disease Director Kris Ehresmann. After those updates, we'll open up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. Across the world this morning, we were above 14.5 million cases and 606,000 deaths. In the United States, as of this morning, we were over 3.7 million cases and 140,000 deaths. We announced today an additional 922 cases from yesterday, bringing our total to 47,107. I'm going to comment a little further about that number in just a few moments. There are some artifacts in the number affected by data conversion that we did that Kris and I will explain momentarily. But clearly that's an alarmingly high daily total, and we have known and been commenting for several days now about the increase in day-to-day cases that we're seeing. The median age of our cases is now an even 37 years old. There are currently 247 patients in the hospital, 115 of those in intensive care. So as our case numbers have increased, we are now starting to see over the last week or so a trend upward in hospitalizations, although, again, we are still significantly below our highest levels of hospitalizations, which we saw in late May. The tests yesterday were the testing volume yesterday was 14,287. And the 7-day average testing positivity rate is 4.7%, an increase from 4.4% a week prior. And as you recall, that testing positivity rate has a 7-day lag factor in it, just due to what we're seeing with turnaround times varying quite a bit among the national labs and some of our Minnesota labs. So just bear in mind that 4.7% positivity rate calculation is actually according to the data from July the 14th. Week over week, though, we've seen a 12.9% increase in total testing volume and an 8.6% increase in new cases. So we are seeing, as we test more, we're seeing more cases, but as some states have noted that they're seeing a larger percentage increases in cases than even in testing, indicating that they're still not testing enough. What this tells us is that the more we test, the more we will find, but we're staying ahead of that ratio. We had a total of 4 additional deaths yesterday in Minnesota, bringing our total to 1,545. All of these deaths yesterday were residents of private residents, none from long-term care facilities yesterday. These were 1 each in Clay, Olmsted, Ramsey, and Scott counties for the deaths. This total includes 1 person in their 90s, 2 in their 60s, and very sadly, 1 less than a year old. We're very sad to report the death today of a 9-month-old who tested positive for COVID-19. Based on what we know at this point, the death appears to be an isolated incident related to this infant's very specific situation. Obviously, out of respect for the family's privacy, we're not going to be sharing more about this case, but our sympathies very much go out to the family, and any COVID-related death is a loss, of course, and a death involving such a young person is tragic and certainly very unusual. As we understand it, this is one of the youngest deaths reported in the country to date. In order to better understand the situation, we've asked CDC to do some additional analysis as well, and Kris may wish to comment further on this if you have questions. COVID can clearly spread through multiple people in households, and this just underscores the importance of developing a plan for an emergency that might prevent parents or adults in the household from caring for their children. Kris mentioned last week the Make a Plan Minnesota campaign, and we would encourage families to learn more about this by going to mn.gov/COVID-19, and you can find the Make a Plan information there. And I'd like to go back to the issue with the very high number of cases yesterday. So those were all the cases that came in from the labs yesterday. Over the weekend, our infectious disease team migrated to a new data management system, which is a really good thing because this new system is better able to deal with the high volume and is more stable for the long-term response that we know we are going to be working on for some time. The conversion went smoothly, and I'd like to really thank all the staff that worked extra hours and hard to make that happen as smoothly as possible. But you noticed that we had a delay in posting the updated numbers this morning, and we know that all of these cases, this 922, have not all been vetted through our typical process. So staff were working on the data conversion, and so you'll see that when it comes to completion of investigations, our numbers for missing and unknown data sources of transmission is higher than normal. And the data themselves, as I mentioned, reflects some cases in the queue that were not fully vetted before today's release of the numbers. So I think what that means, and Kris can explain this better than I can, is that there'll be some kind of abnormalities in the data over the next few days as a result of this data conversion. They will ultimately be all sorted out, but we may see some unusual numbers over the next couple of days just because of this data conversion. This is a really good thing that we've made this move, but it is going to cause us a little bit of inconvenience in the numbers over these next couple of days. However, it is certainly the case that the cases are going up. They've been going up. We know there are more cases in the pipeline, so to speak. So in that sense, today's number is sobering, certainly, but not a surprise. So with that, I'll turn it over to Kris and see if you can add a little more clarification to the number situation, Kris, and the data conversion.
Thank you, Commissioner. As the Commissioner said, over the weekend, our MDH Infectious Disease Operations team migrated us to a new data management system. And the reason that we did this is that this system will be better able to deal with the high volume of cases that we're seeing each day, and it's more stable for the long-term response that we know that we're facing. Additionally, we chose to make this migration because the system that we're now using combines both the laboratory and the case data into a single system, which for the epidemiologists and the team that is doing the case and contact investigations, that is really helpful. It's also the system that we've used with our other disease reporting, and so it will allow us to streamline our work for workflows and case assignments. And the Minnesota Minute IT team is also a really strong partner with us in using this system, and so they'll be able to help us as we continue forward using this new system. Additionally, this is a system that both internal and external partners routinely use, and so will be beneficial in that way. And in the process of building out features and upgrades to this new data system, it will benefit all of our infectious disease work. So this system is used by other infectious diseases for surveillance. And so although it benefits us now for COVID, it also benefits our infrastructure for our ongoing infectious disease response. So those are the reasons that we were looking to make a change to the system that we had been using. As the Commissioner said, in the process of making this change, we're finding ourselves in some choppy waters as it relates to our data. So as she said, we reported 922 cases for today, but some of those cases, in fact, 665 of those were still in the queue. We found ourselves in a position of having 257 cases that had gone through the entire formal process and knew that that was not accurate in terms of the total number of cases that we were seeing, but also know that by reporting numbers that are in the queue, that there will be corrections that occur over the next number of days. The reason that this may sound confusing is that we are continuously getting in results from laboratories. So it's not like laboratories all report by noon and then we don't get any more reports in until the next day at noon. It's constantly rolling, and so we have to sort of cut the numbers at a certain point in time. And what happened this weekend with the conversion is that the process was slower. We had staff who normally would be working on processing new laboratory results who had to work on assisting with the migration. We also had a new process for staff to learn, so that slowed things down. As a result, we had a bottleneck in terms of vetting results. And so we know that the number of results that ultimately went through as vetted were insufficient to reflect the true number of cases that were seen yesterday. On the other hand, we want you to know that the number of cases that we reported today include cases that were in the queue and had not gone through that vetting process. So over the next days, our data will be a little bit choppy as we continue to go through vet cases, add staff to help pull us into this new system. So it's a situation in which we were all celebrating on the weekend because sometimes when you do data migrations, you can have systems crash, you can have all manner of strange things happen. And we did not have that, and our team did a really great job. But it did slow down the process of vetting, and so we're in this position of having data that is going to be modulating over the next couple of days. So I want to be clear on that. I want to explain kind of where we found ourselves and in the challenging place of how do we reflect where we're really at a time when things in this migration mean that things are constantly moving. So I hope that was helpful. I'm sure you'll have plenty of questions, but with that, I will turn it back to Mike Schomer, and we will be happy to take your questions.
Thanks, Kris. As we open it up for questions, we'll ask that reporters limit themselves to one primary and one follow-up so we can get to as many as possible. With that, operator, we are ready to take questions.
All right. Again, ladies and gentlemen, if you have a question at this time, please press star then one. And it looks like our first question is going to come from the line of Jeremy Olson with Star Tribune. Your line is open. Please go ahead.
Kris, Janet said that you might be able to provide some information on the CDC doing some additional analysis of the infant case. If I was listening correctly, can you provide that additional perspective? Why have you asked for that? I know you can provide more details on the death itself, but maybe on what you're trying to learn from it?
Oh, certainly. Well, as the commissioner said, I mean, an infant death is devastating, and thankfully there have not been a lot of infant deaths in the country. But we want to make sure that we're understanding as much as we can about this infant's the physiologic changes that occurred with this infant in terms of the progression of their illness, as well as we want to make sure that any information that's available on the course of this infant's illness is added to the broader understanding of infant deaths across the country. And so the specimens that were collected to be evaluated here are being sent to CDC so they can do additional evaluation. And that's not to suggest that the evaluation done here was insufficient. That is absolutely not the intent, but rather that these data and this information, CDC can look at it and can provide us with more information, and then it can become part of the greater scientific knowledge about deaths in infants related to COVID. Does that
And as
help
a follow-up,
answer that? Yep.
it does, and you talked about this being a unique situation, but in other deaths you've characterized whether there were underlying health conditions. Would that be accurate in this case if this child had some sort of disorder or an underlying health condition that was relevant?
Oh, you know what? I can say that the child did not have an underlying health condition.
Okay, thank you.
Yep.
Thank you. And our next question comes from the line of Tim Nelson with NPR News. Your line is open. Please go ahead.
Yeah, I'm a little curious about the Department of Public Safety's availability earlier today. They're talking about doing nearly 1,000 visits to bars and restaurants around enforcement. And we're also talking about a possible mask mandate here. If they're going to that many bars and restaurants and writing these citations, are you at a point where you're starting to weigh recommending another shutdown?
Well, I think this is Jan. We've reported also that we've been doing additional enforcement through our environmental health staff at both the state health department and local health department. So I think that the focus, has been and is on making sure that everybody knows what the current executive order rules are and knows the importance of complying with them and the penalties that can come with not complying with them. We definitely have had and will keep our eye on what we know about any clusters associated with bar and restaurant cases and whether those are increasing or decreasing as a matter of this stepped up enforcement action. But we're also talking with others around the country to see what effect any changes in bar and restaurant operations have had on transmission rates. So it's, as I think I said last week, it is always a topic of ongoing conversation. We've not made any specific recommendations yet, but that will be a conversation ongoing.
As a quick follow-up, I'm watching Beltrami County. It looks like they've almost doubled in cases. It's not a big number, but a significant jump in the last week. Any idea what's going on up there?
Kris, can you answer that one?
Sure. Yes, there were a number of events, athletic events and different things like that people had been engaged in that we know were linked to transmission. So we're aware of what's happening in that area and we're aware of some of the activities that have gone on. So does that help? It's a combination of multiple things, but gatherings, events, athletic activities, that type of thing.
Thank you.
Thank you. And our next question comes from the line of Emily Havoc with KARE 11. Your line is open. Please go ahead.
Yeah, I'm wondering if there's anything else you can tell us about the infant death. I understand the privacy concerns, but can you tell us what the infant symptoms were, how the case was identified, if you know where it was contracted, any of those details available?
This is Kris Ehresmann. Well, a couple things. In general, with young children, most exposures tend to be household because that's the focus of their activity. And the child had, symptoms of COVID. So in other words, some of the expected, respiratory symptoms, that type of thing, and did show evidence of some inflammation in the upper airways. So, I guess to say symptoms consistent with what you might expect from COVID.
And then do you know how long the child was in the hospital?
The child was not hospitalized.
Okay. Yeah, I guess with no underlying conditions, anything else you can tell us about why you think it was a fatal case?
I think that's part of the reason that we're that we're hoping that by providing some of the specimens to CDC, that collectively, as we look at infant deaths across the country, that will help inform this. I mean, obviously this is very rare. This is the first and only death that we've had in anyone under 20. And if you look nationally, the number of deaths in very young infants is very small. And so there's just a lot that we don't know. And so our goal is to help to contribute to that understanding so that it will help us going forward.
Thank you. And our next question comes from the line of Catherine Rickert with Minnesota Public Radio. Your line is open. Please go ahead.
Hi. So I noticed that there is an uptick among people in their 30s, 40s, and 50s. We kind of understand the uptick in people in their 20s right now, and it looks like people in their 60s and 70s have plateaued out. I'm just wondering if you have any thoughts on why we're seeing an uptick in that sort of middle-aged group right now. What's behind that?
I'll turn that one over to Kris as well. Thanks, Kris.
Okay. Yeah, I think that what we're starting to see is more activity in all of our populations. So because of increased engagement with other people. So I think if we look at how cases have changed over time, certainly we talked about initially in the outbreak, we were seeing a number of cases in older individuals because our focus in testing was in that most vulnerable group of individuals who were in congregate care settings. We also started to see a shift then as we started to see more workplace outbreaks. And so we saw a gradual shift downward in some of our case ages because we were looking at individuals in the workplace. And so we saw a gradual shift there. And those early cases were because they were in critical infrastructure, because we were focusing on testing there. Now we're at a place where we've had more opening up within the state, and we're seeing many more people of all ages engaged in more social activities and more interaction. And so initially we were seeing a lot of cases in the 20-somethings simply because we saw a lot of cases that were tied to particular bar and restaurant outbreaks. And now as we see cases in individuals who are a little bit older, what we're seeing is the impact of broader gatherings, whether it's, get-togethers, family get-togethers, people that are enjoying the summer and not social distancing like they could. So we're seeing this evolution of who is getting COVID because of how the evolution of our activities. And so that's how I would describe this older group. It's not focused, it's not particularly necessarily the bar scene like we saw with the 20-somethings, but it's part of that gradual increase in social activities.
And if we were to do a mask mandate, which I know is being discussed, how would a mask mandate affect those sorts of gatherings you just described? Because I don't think you can force people to wear masks if they're having a barbecue in their backyard, right? And if that's the real issue, does a mask mandate do much to change that?
Well, this is Jan. I'll comment first and then certainly welcome Kris's insights as well. Yeah, you're right about the specific nature of a gathering and whether people would be inclined to wear masks at a barbecue or not. However, I think the mandate just would serve to just reinforce the expectation that it is the norm to wear a mask in most circumstances in which you're out in public and interacting with other people, particularly in close proximity. And so we do believe, and I think the data have shown that in areas, states, countries with mask mandates, it does materially increase the usage rate of masks, and we see it translate into reductions in cases as well. Kris, anything to add?
No, I'll just reiterate what you said, that there's increasing data that suggests that masks have a real utility in helping to prevent transmission of COVID. And so there's definitely many benefits to having people wearing masks in indoor settings. And as you said, people, we don't have sufficient staff to enforce every situation, but I think it sends an important message about the value of masks.
Okay, thank you.
Thank you. And our next question comes from the line of Nora Hertel with St. Cloud Times. Your line is open. Please go ahead.
Thank you. I'm hoping you can talk a little more generally about COVID among young children. I know you said there's a lot that we don't know, but can you just share what has been shared by experts into the risks of kids getting infected? Obviously, really little kids can't be wearing masks. So also any recommendations you might have to protect that age group.
Sure. Kris, will you take that?
Sure. We know that when we look at transmission in settings where kids are gathering, for instance, when we look at data from, say, our child care settings and things like that, that we've seen that it has typically been adults who have brought COVID to the setting. We're seeing less transmission that's driven by children and more situations in which an adult develops COVID from their other activities, and then we see it, in the setting where kids are gathering or in a household. I think that in general, we have seen fewer cases in kids. We've seen fewer cases with hospitalizations and fewer cases with the need for intensive care. But what we don't know, and I think this is true for all ages, is we don't really know the underlying sort of long-term impact of a COVID infection on an individual. And so that we're wanting to learn more about that. So even as I talk about the fact that, kids tend to have a milder illness, fewer hospitalizations, all of those things, we want to acknowledge that we're continuing to learn about this illness. But in general, when we've seen transmission in the younger ages, it tends to be more adults kind of bringing it to, say, the child care setting, that type of thing, rather than going from child to adult.
Okay, thank you.
Thank you. And our next question comes from the line of Carla Holt with CARE 11. Your line is open. Please go ahead.
Thanks so much. Appreciate it. So I just wanted to clarify for our most accurate representation, did this infant die with COVID-19 in an infection or die as a result of the COVID-19 infection, just to make sure that we accurately represent this in our reports? That is my first question. Then I just wanted to add to that the question regarding, we recognize this is an infant, 9 months old, but given the symbolism, given how it will really grab families throughout our community, could this play at all a role as the governor and education commissioner and yourselves continue to mull the school decision that is expected any day now?
Well, let me answer that last question first. This is Jan, and then perhaps Kris can back up on any kind of guidance to families. As Kris said, statistically, this is exceedingly rare, and that is of absolutely no comfort when a family loses a child or loses any loved one. But I think you're right. It's bound to grab attention. It does underscore, as Kris said, that there's much we don't know, and as we've been reporting all along, occasionally there's a very bad outcome from COVID-19, even among people who are not in known higher risk groups. So that is certainly a harsh reminder of that reality. Whether and how it affects the decision on schools, I think we need to look at all of the data, keep all of the data in context, and certainly we know what an important issue this is to so many people for so many reasons, and we will just be as transparent as we can be with the information and the data on which we're basing our guidance and our advice. But again, I guess I would just say there's already an awful lot of focus, lots and lots of different perspectives, passionately held perspectives on this issue that we've been, the Department of Education has been working just so hard to collect input from parents, teachers, other stakeholders, really since early March. They've just been in constant contact with stakeholders to be able to understand perspectives and address questions and concerns. So they certainly have been and will continue to do that as this decision is considered and ultimately rolled out.
And then this is Kris, and I'll just add to your question, sort of parsing died with COVID or as a result of COVID. The child was identified as having two causes of death, upper and lower respiratory tract infection and a nasal culture positive for COVID-19. So the child clearly had evidence of a respiratory infection and did test positive for COVID. And how significant the COVID infection was, that is, I guess, for the medical examiner to comment on, but definitely that was listed, the cause of death was listed as upper and lower respiratory tract infection and nasal culture positive for COVID-19. And as I said, we may learn more from CDC, but at this point, we know that the child did have COVID, and we are including it, unfortunately, in our death totals.
Thank you for that. And just a quick clarification as well on the data and how it has changed as regarding your whole management system change. When you say that you have 600 plus cases in queue, how many of those 600 plus cases can we expect will actually amount to positive COVID infection cases? Do you have any estimate, a vast majority or half or?
Yes, I would say a majority will count, but we do, part of our process, our workflow process is that we, look for duplicates, we make sure that everything makes sense, and you'd be surprised at how time-consuming and complicated this is. So I would say that we expect to see that a majority of those in the queue will continue to be counted. But we were in a very challenging position where nothing we were going to do today was going to be right, was going to be right on. And so we wanted to talk about the challenges that we faced, but we also wanted people to recognize that even as we are in the midst of this transition in data systems, we know that our case counts are going up. And so we're working to get through the bottlenecks, through the backlogs, to make sure that we've vetted all of the cases, and that will be happening this week. But we certainly don't want our transition and sort of the hiccups that go along with that to suggest that something has changed in terms of the trajectory of cases, because unfortunately that hasn't happened. So yes, I would say that the majority of those in the queue should, once vetted, will turn out to be cases.
Operator, we have time for one more question.
All right. And then our last question will come from the line of Tim Boltz with Fox 9. Your line is open. Please go ahead.
Great. Thank you, Commissioner. Thank you, Kris. A quick question for you. As we have more retailers and businesses that are now requiring people to mask up. I mean, today we've got Kowalski's, we've got CVS, we've got Walmart and Sam's Club, and before I jumped onto this call, the MAX Airport Commission was looking to require people to mask up at MSP Airport as well. The question is this: does that allow you now, or does that weaken perhaps MDH's argument for a statewide mandate?
This is Jan. It's a great question, and certainly we've been appreciative of the local leadership and the business leadership in adopting, these policies on their own. We do still believe that there's value added from a statewide mandate for consistency of messaging, and so that people don't have to wonder now, is this a county or a city or a business that requires this or doesn't require this? We want to support those local decisions, and I think many in our public health community find great value in just the consistency of a statewide approach. And as we've mentioned before, that is often the way in public health issues, that local action builds momentum that then makes it more helpful and easier to just magnify that message with a statewide policy approach. So that continues to be what we are recommending, and the governor is considering.
Can you break any news? Is the governor going to make that announcement soon?
No, I don't have any news to break today for sure. I think he's been commenting, I know, in his press calls or press appearances, that he was encouraging the legislature to take that action, that he thought that would be a good show of the executive branch and the legislature working together. I wasn't a part of those conversations, so I can't really comment on the nature of them. But I know that's been something that he's been also working on.
My thanks to you both. Thank you.
That's all the time we have this afternoon. If you had a question we were not able to address, call. Please feel free to reach out to the MDH Communications Office. Have a good day, and we'll be back with you again soon.
Ladies and gentlemen, this concludes today's program. You may all disconnect. Everyone, have a great day. 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 Everyone, have a great day.